Right, here we go. So this is a TOG summary for the most latest version of TOG, which is TOG July 2022. I've done this in two-part videos. So this is part one covering some of the articles, and then I've got another part two prepared that's got the rest of the articles. I hope you'll find this summary useful. So the first article here is the Advanced Abdominal Pregnancy Challenges Update and Review of Current Management. Abdominal pregnancy is it's an ectopic pregnancy. It's within the abdominal cavity and excludes ovarian, tubal, intraligamentary pregnancies. Advanced abdominal pregnancy is a pregnancy that's over 20 weeks of gestation. Incidence is 1 in 10,000 and 1 in 30,000 live births. That's approximately 1% of ectopic pregnancies. Maternal mortality is anywhere between 0 and 12%. Fetal survival is actually surprisingly over 78%. In 1942, Studiford minimum criteria to define a pregnancy within the abdomen was as follows. So, normal tubes and ovaries on scan, absence of any evidence of a utero-peritoneal fistula, presence of a pregnancy related exclusively to the peritoneal surface, and early enough to eliminate the possibility of secondary implantation following a primary implantation within the tube. Secondary abdominal pregnancies, developing fetus can reimplant within the abdominal cavity following a ruptured tubal ectopic pregnancy or following rupture of rudimentary horn or dehiscence of uterine scar. Risk factors, so like any ectopic pregnancy, so things like previous ectopic pregnancy, tubal pathology, including surgery or infection, and current use of an intrauterine contraceptive device. Specific risk factors are the presence of uterine anomalies and history of previous uterine surgery, example, cesarean section, previous myomectomy, and post-uterine perforation at surgical termination of pregnancy, also following IVF treatment. So the commonest presentation is abdominal pain with or without vaginal bleeding. The abdominal pain is present throughout the pregnancy, so it's persistent abdominal pain and is exacerbated by fetal movements. The diagnosis is commonly made following fetal demise. Diagnosis of advanced abdominal pregnancy intrapartum can be made if there is failure to induce labor. Oxytocin stress test can be used as one of the ways to diagnose abdominal pregnancies, which means that there is absence of uterine contractions despite putting up in an oxytocin drip. A displaced cervix, usually anteriorly, is a reliable sign of advanced abdominal pregnancy. So symptoms and signs of advanced abdominal pregnancy. Symptoms include abdominal pain, vaginal bleeding, painful fetal movements, reduced fetal movements, bloating, and vomiting. Signs include palpable fetal parts, deviated cervix, anemia, abnormal fetal lie, small for gestation age, oligohydramnios, failed induction of labor. So ultrasound can be used and it helps to pick up an extrauterine amniotic sac and an empty uterine cavity. MRI should report the following. So for the fetus, it should report the viability, lie, position, and relation to the uterus and maternal intra-abdominal organs, presence of congenital abnormalities, signs of fetal demise, maceration, or hydrops. For the amniotic sac, the MRI should report on oligohydramnios, signs of rupture of amniotic membrane, and for the placenta, the position, the site, the extent of implantation, the blood supply, the presence of placental adherence to the surrounding organs, presence of bleeding from placental bed, or placental infarction. Uterus, assessment of uterine cavity, integrity of the cervix, uterine wall, signs of uterine rupture, presence of intra-abdominal fluid or hemoperitoneum, maternal findings, and comorbidities. So management is can be a termination of the pregnancy or expectant management. So termination in the UK, feticide is recommended for termination above 21 plus 6 weeks of gestation, and that's usually done by intracardiac potassium chloride injection. Expectant management, where the minimum requirements for expectant management should be confirmation of diagnosis and placental localization. So expectant management should be done as an inpatient, which means the patient stays in hospital. The significant risk of life-threatening intra-abdominal hemorrhage with a development of venous thromboembolism, so they should be given prophylaxis for this. Regular assessment of maternal well-being using the modified early obstetric warning score, which includes things like heart rate, respiratory rate, and blood pressure, and so forth. Um, Full blood count at regular intervals, group and screen, which means that should be done regularly as well, so it's not expired in the lab in case blood is required. Assessment of fetal well-being, fortnightly ultrasound scans of fetal growth, Leica volume and Doppler, in addition to CTG and maternal fetal movements, 24-hour access to blood products, access to interventional radiology, continued MDT input. Timing of delivery is individualized. Risk of prematurity should be balanced against maternal well-being. There's no clear cutoff. Consider delivery from 30 weeks of gestation. So pre-operative planning checklist includes, so pre-surgery, you want to optimize maternal hemoglobin, so things like iron supplementation or blood transfusion, pre-operative MRI, which then helps you to plan as to exactly whereabouts is the pregnancy, where is the placenta adhered to, because some of this placenta could be on very important vascular structures, so you want to know all of this before you plan delivery. Informed consent, including additional procedures as per placental assessment. Setting should be in a tertiary center hospital inpatient. MDT should include your senior obstetrician gynecologist and senior assistant, fetal medicine specialist, senior anesthetist, hematologist, senior interventional radiologist. Surgical team should include your urology, colorectal, upper GI, vascular, experienced gynecology surgeon, and senior neonatologist. So a midline or a paramedian laparotomy is done under a GA. The placental site could be single or multiple sites, and is the cause of morbidity and mortality in abdominal pregnancies, where there is deep implantation of the placenta on highly vascular intra-abdominal structures. There's no consensus about placental management, so whether it should be left behind or removed. So these are the sites of placental implantation which have been extracted from 182 cases. So site of placental implantation, uterus and adnexa, bowel, omentum, broad ligament, pelvic wall, abdominal wall, pouches surrounding the uterus, bladder, peritoneum, upper abdomen, and major vessels. So leaving the placenta behind increases risk of maternal morbidity because the placental mass can form an abscess leading to sepsis and necrosis. Also, there can be paralytic ileus, secondary hemorrhage, disseminated intravascular coagulation, so DIC, return to theatre, fistula formation, persistent hydronephrosis, and prolonged hospital stay. Regular ultrasound scans and serum beta HCG levels can be done to assess placental involution. However, this can take some time even up to 5.5 years. The hormonal function declines more rapidly between 10 days to 7 weeks. To accelerate resorption when the placenta is left behind, methotrexate has been administered. However, it's not routinely used because of significantly high risk of infection. Uterine artery embolization has been known to be done in order to minimize blood loss. Now, complications for abdominal pregnancy for the fetus include oligohydramnios, fetal growth restriction about 24%, intra-abdominal fetal demise about 36%, neonatal deaths secondary to prematurity, pulmonary hyperplasia, severe deformities, and chorioamnionitis, and perinatal mortality rates are between 72 to 83%. Maternal complications include life-threatening intra-abdominal hemorrhage, persistent and/or worsening abdominal pain, acute intestinal obstruction, bilateral ureteral obstruction, bilateral hydronephrosis, preeclampsia, intraoperative hemorrhage. Subsequent blood transfusion is required in 70 to 90% of cases. Infective complications, which include minor wound infection, placental abscess, fistula formation, and peritonitis. Relaparotomy may be necessary either in the immediate postpartum or even several months after the procedure associated with the placental mass. Okay, that was that article. Now we move on to our second article, which is titled as Present Status and Advances in Bladder Pain Syndrome, Central Sensitization, and the Urinary Microbiome. So bladder pain syndrome is more common in women compared to men. Prevalence is between 2 and 6%. The patients may display a mild form of disease which can be treated in a outpatient clinic setting. Others may have quite debilitating disease and may require repeated hospital visits. MDT management, which includes specialists in psychology, pain management, urology, and urogynecology, are required to manage the condition. Bladder pain syndrome is commonly associated with depression and anxiety. The bladder mucosa is lined by a protective proteoglycan layer. The proteoglycans are quite large and heavily glycosylated proteins. They're composed of a protein core and a aminoglycan side chains, GAG for short. They densely cover the luminal surface of the bladder, forming a hydrophobic barrier that prevents the permeation of bacteria, proteins, and urinary solutes into the underlying muscle and nerves. This layer may be dysfunctional in bladder pain syndrome. So things like pentosan polysulfate sodium has a similar structure to the GAG and is therefore used as a treatment for BPS as it helps to replace a damaged urothelial barrier in patients with BPS. So precise trigger leading to BPS in women with bladder pain syndrome is unknown, but things like irritant chemicals, radiation, blunt trauma, childbirth, infection, urological instrumentation, or surgery triggers the release of inflammatory mediators, leading to disruption of the protective mucosal proteoglycan barrier. Ketamine, which is a dissociative general anesthetic that is occasionally abused as a recreational drug, can cause a form of cystitis known as ketamine cystitis, and the symptoms are very similar to bladder pain syndrome. Immune cell proteins. So when there is trauma to this barrier, there's release of immune cells, which then induce hyperalgesia effect by increasing the nociceptor channels on the afferent nerves. These then send signals of actual or potential tissue damage to the spinal cord and the brain. This leads to neurotransmitters like the substance P and the calcium gene-related peptide released. This is followed by the development of neuropathic pain. This diagram just illustrates what we've already said in just a diagrammatic form, which is just easier to visualize and learn. Okay, this graph again shows how there is a normal pain response and how that pain response is shifted in hyperalgesia effect, and at quite lower thresholds pain is stimulated and the pain score intensity goes up. So central sensitization group of disorders are disorders that have common symptoms, but there's no underlying pathology, and with pain being the leading feature. Things like fibromyalgia, irritable bowel syndrome, temporomandibular joint disorder, chronic fatigue syndrome, vulvodynias, and headaches. So amitriptyline is a tricyclic antidepressant and is used to treat neuropathic pain. It suppresses the reuptake of noradrenaline and serotonin at the presynaptic nerve endings of the central and the peripheral nervous system. Success rates are reported in 45.5 to 66%. Use is quite limited to lower doses, mean dose between being 55 milligrams, ranging from 12.5 to 150 milligrams, owing to significant side effects such as dry mouth and weight gain. 84% of patients at the higher, more effective doses again experience side effects. So peripheral neuromodulation, including sacral nerve stimulation and posterior tibial nerve stimulation, is also used to manage BPS. Clinically significant improvements in up to 50% of patients are noted. So peripheral neuromodulation, like the posterior tibial nerve stimulation and sacral nerve stimulation, can lead to significant improvement in symptoms of patients with chronic pelvic pain and bladder pain syndrome. So there's also deep brain stimulation, which is neurosurgical treatment. It involves septal and medial forebrain stimulation, which has analgesic effects and mild euphoria, feelings of warmth, well-being, and relaxation. Significant improvement in urinary incontinence and frequency in Parkinson's disease patients following deep brain stimulation has been noted both in men and women. Repetitive transcranial magnetic stimulation is a non-invasive therapy that uses magnetics to induce a transient electric current in the cortex underlying the magnetic coil. It results in a reorganization of the pathological neuronal networks. So urinary microbiome. So bladder has a healthy bacterial flora called as the urinary microbiome. In healthy females, the most abundant genre of bacteria found in the bladder include the lactobacillus, prevotella, streptococcus, and gardnerella. Bacteriuria is present at the onset of bladder pain syndrome in some of the patients with BPS. So this table is a summary of studies detailing results of antibiotic treatment response in patients with BPS or painful lower urinary tract symptoms. Treatment led to resolution of symptoms. So I'll give you a couple of minutes just to go over this yourself. Okay, so management of bladder pain syndrome. So you can see it involves lifestyle modifications, oral therapies, intravesical medications, bladder distension, and neuromodulation. So lifestyle things are things like dietary modifications, avoid caffeinated beverages, alcohol, citrus fruits and juices, spicy foods, tomatoes, carbonated drinks, chocolate, as these are irritants to the bladder. Avoid constipation can worsen bladder symptoms. Smoking cessation, nicotine is a bladder irritant. Avoidance of UTI, increase water intake as concentrated urine can irritate the bladder. Bladder training, avoid frequent micturition just in case to prevent bladder shrinkage. So avoiding going to the toilet just in case, um, that kind of basically thinking where you're having to go too often, and that also can irritate, can prevent, um, it can lead to, so avoid frequent micturition to prevent bladder shrinkage. So oral therapies, as we said, we can use this almirone, which is a pentosan polysulfate. So mode of action is replacement of urothelial barrier. Effect on the bladder is analgesic effect. Side effects is retinal pigmentation. Anticholinergics increase bladder capacity and reduce detrusor contractions. So effects on the bladder, controlled frequency, urgency urinary incontinence. Side effects are dry eyes, dry mouth, and constipation. Treatments such as analgesias like amitriptyline, which is tricyclic antidepressant, leads to bladder relaxation at low doses. Analgesic effects with higher doses. Side effects are nausea, blurred vision, skin rash, and constipation or diarrhea. Antibiotics, low dose, long-term antibiotics may lead to symptom improvement. Intravesical medications like your cystistat, so it's bladder mucosal gag replacement therapy, providing analgesic effect. Then you've got another one similar to that one, which is shortened to IA LURIL, bladder mucosal gag replacement therapy, providing analgesic effect as well. And then you've got your intravesical botulinum toxin A. Botulinum toxin bladder injections inhibits acetylcholine release, resulting in temporary flaccid muscle paralysis. Bladder distension, cystoscopy, and hydrodistension allows confirmation of diagnosis. Low pressure hydrodistension provides relief of frequency and urgency. Neuromodulation with posterior tibial nerve stimulation, fine needle electrode is inserted at the ankle to stimulate the tibial nerve. Weekly sessions for an average of 12 weeks is required. Sacral nerve stimulation, so impaired nerve device for stimulation of the sacral nerve, used for the treatment of severe urgency, frequency, and urinary retention. Well, thank you so much for listening. If you found this summary useful, then please do give this video a thumbs up and subscribe to my channel so you can keep yourselves updated. And please leave a comment below if you found any of these slides useful and if you would like to watch more of these summaries. Good luck revising.